supporting Fine's effort to expand access to effective diagnostic testing. She's been leading Fine's COVID response, including creation of the Access to COVID Tools or ACT-Accelerator Diagnostics Partnership, co-convened with the Global Fund. Dr. Hannay is a public health doctor with a focus on global health strategy and delivery. Her work has been centered on organizational strategy and global health, and at a country level, implementing health systems reforms in complex operating environments. In her previous role, head of health at Acasus. That's right.
Good job.
Thank you. I didn't know.
We only made it up when we started Acasus, so we can present it any way we like. It honestly stands for absolutely nothing. So
Okay.
We can call it like that.
So a long tradition of acronyms or names, which don't necessarily in global health. But as head of health at that organization, she helped design and lead the Pakistan Health Performance Roadmaps, which improve primary care for more than 150 million people, and the Democratic Republic of Congo's Mashanko plan to increase immunization coverage for children. And so today she's joining us to discuss, as the topic shows, from strategy to delivery, lessons on scaling up innovative technology from the COVID-19 pandemic. Thank you again for joining us. Thank you all for coming, and I will hand it over to you now.
Lovely, thanks, Justin. Where's the best place to speak for microphones, or can you hear me?
Probably that's a left turn.
Yeah, I was going to say that, but messages came up in the chat that
That audio is bad. Is
Yeah.
that better, folks? Can you hear me well? Can you give us a thumbs up for Divya, or if it's better?
Let's switch microphones.
if someone online could just say it's better now. Okay,
Or-
I think we got a thumbs up.
Fantastic.
Yeah.
Let's do it.
Yes. That's great.
So thanks all. What I thought I would do was to talk a bit about, from a bit of an insight perspective, around how, especially driven by the COVID pandemic, we looked at developing and scaling new innovation in diagnostic testing. And think of it as a case example for other innovation, other products and vaccines and medicines, or even different services in global health technology. And I think a lot of those same lessons apply here for diagnostics. So think of it as an interesting case example on a much broader topic around innovation. I'm going to talk about it through a couple of different lenses, and we'll get into that in a minute, and also sort of walk through a little bit what happened, which many of you might remember from the COVID pandemic. Are you driving the slides today, Divya?
No, I can
Can I drive them?
It's a quick
Oh, sorry, I can drive them. Fantastic. So super briefly, so who is Find? So Find is 20 years old this year. Find was born as a product development partnership in diagnostics. So it's got a broad category of different organizations that exist in global health to help kind of bridge the gap between the kind of technologies that we need for health systems in low middle income countries and what's available. So there's product development partnerships that exist in medicines and vaccines for things like bed nets and other technologies, and Find for diagnostics. But I would say, I think Find, actually all PDPs, and especially for Find, because one of the big challenges that we saw was that we were developing a lot of diagnostic tests that weren't getting taken up and used within health systems. Like others, we then started to develop more and more work around how do we help integrate diagnostic more effectively within health systems and drive better access to the innovations that were coming on to market. So Find really works in an end-to-end way around the world. So we have a number of country offices that work through a whole network of partners, also with industry in developing new diagnostic tests, as well as with country governments and other country stakeholders. Find is a WHO collaborating center, which means we do kind of technical stuff to be able to help inform clinical guidelines and things like that, as well as, and we'll talk a bit more about this partnership, co-convening with the Global Fund, the ACT-Accelerator Diagnostics. So super briefly, and I think just to really frame up the topic around the uptake of innovation and innovative technology within health systems. And this, broadly speaking, these two different lenses, and I think I just wanted to sort of anchor this in some of these frameworks, and we'll come back on some of these later. The first one is a really technology-centric lens, and the classic framework in this space is obviously the Rogers diffusion of innovation theory work, which many of you know is published in the 1960s, often used in the tech space and other spaces today. But interestingly, you know, Rogers was actually a professor of agricultural technology, and it actually came from fields around uptake of new innovation in farming, and we then applying to healthcare, which is an interesting an interesting background for this otherwise kind of rule of thumb frame, which really describes the different factors that help affect whether a new innovation gets taken up within a system, in this case within a low middle-income country health system. And the factors that Rogers identified included the relative advantage of the innovation, vis-a-vis whatever the status quo was in that place, how trialable or how testable the technology is, whether you can really kind of put it in your hands and touch and feel it, like an Apple Store technology, how observable the change in that innovation was, so whether you could really see a difference, see that you were using the newest and brightest technology and your neighbors could see it, and how that sort of led to the uptake of that technology. How compatible it was within the systems that it was deployed. You can imagine when it comes to diagnostic testing, how easy it is to integrate that into regular clinics and the regular sort of flow of health systems, and how complicated that innovation is. So I think those are just some lenses when we talk about the different diagnostic tests and how they came to market. It's sort of helpful to keep in mind. There's also just a much more politically systems-focused lens around uptake of ideas and innovations. And there's many different frameworks in this space, some of which come from LSHTM and LSE, but one of them is Jeremy Schiffman's set of different rules of thumbs that drive different political priorities within them. And I think that's really relevant when thinking about global health politics, global health partnerships, like we're going to talk about with the ACT-Accelerator. And he talks about these 4 different factors that affect how you get an idea or agenda up in the global health architecture and global health systems, including the relative strength of the actors that are involved, the power of the ideas and how those issues are portrayed, the sort of nature of the broader political context in which those ideas spread, and then characteristics of the issue itself. So how easy is it for a particular issue to draw the imagination and interest of different actors within that space. So it's very much more of a political science lens. But I think because we're going to talk about the creation of a partnership for the COVID response and diagnostics, and then the individual technologies, I think both of these have some really interesting ideas, and we should come back to them. So we're going to illustrate a few different relating to both of these as we go along. Fantastic. So I think we have to anchor a little bit in what are diagnostics and what did the state of diagnostics in low middle income country health systems look like before the pandemic. Because for many people, and probably many people who are online and in this room, your first real exposure to diagnostic testing probably was COVID. That's probably the first time you had boxes of tests sitting in your cupboards at home, I'm just going to guess. So let's talk a little bit about what they look like before and what testing looks like. So diagnostic testing is typically, the technical term is in vitro diagnostic testing, which is some sort of usually laboratory type test that's used to confirm the presence or absence of disease. And usually what that involves is some sort of either disposable rapid test, like a pregnancy test or something that people can do at home, right through to like pretty complex POC. Here means point of care machines that can be used in laboratories to be able to test for much more complicated diseases. So a lot of these are just chemical reactions to identify the presence or absence of either a disease or part of the body's response to that disease. And so most diagnostic testing has historically happened within laboratories that would be attached to hospitals. Samples would be taken in clinics and sent to those laboratories for testing, and results would come back. Although the vast amount of diagnosis that would go on would essentially be clinical judgment. So only a small amount of diseases would actually receive complementary testing that said you 100% have tuberculosis or some of that. There's been really quite significant technology advances even pre-COVID, and this slide hints at some of those, because this is really an engineering and computational problem, right? It's not quite the same as a drug discovery problem where you get one molecule after 30 years of research. This is really about engineering, chemicals, manufacturing, scale up for diagnostic testing. And so a lot of, even pre-COVID, the work had been around moving these huge laboratory machines, which, if you can imagine, were hard to deploy within low middle income settings where you needed clean spaces, reliable electricity, where you needed sample transportation networks, quite some expertise in laboratory workers, to be able to shrink and miniaturize and simplify that technology so it could be deployed within hospitals and clinics. And there had been that movement that had started to happen in COVID. One of the most famous examples, which FIND was involved in, was the creation of the Gene Expert machine, which was a test for tuberculosis, but now a number of other products. And that's a product that goes from a machine that's like the size of this desk that needs a few experts to something that's like the size of a microwave that you can sort of put sputum in and get a tuberculosis sort of test. So in the world of TB, that represented a real step change for the diagnosis of TB. It had been 120 years before that since the last evolution in the TB diagnostic space with the invention of the microscope and smear microscopy. So it's not on a very fast innovation. But we'll talk a little bit as this presentation goes on about how fast some of those innovations cycles. So that's what a diagnostic test is. It's a medical device technology, confirms diagnosis for patients and for clinicians, often very used in infectious diseases or non-infectious diseases to tell, really for sure whether or not you have a disease. So what was the status of diagnostic testing pre-COVID? So this is work from the Lancet Commission on Diagnostics, which was published in 2021. Most of the work predates COVID. And what you can see on the slide here on the heat map is a bunch of basic diagnostic tests that should be available at different levels of the health system and various country surveys on their relative availability. And what you can see, especially on the left side, which that box, it's a big red box, is that most primary care systems, and that's what that box represents, had no availability of pregnancy tests, HIV tests, malaria tests. These are all simple little cartridges with fancy paper in them that you do a single test and dispose. Perhaps glucose tests for diabetes, which is a smaller device that you do a finger prick test on. Perhaps hemoglobin, which again can be a pretty small, simple device. But if you look at the availability of primary care, these basic tests that doctors need to be able to provide quality care, they just weren't there. It was a slightly better situation in hospitals, which is that box that you can see, the heat map box that's a little bit more blue and green. But broadly speaking, there was no diagnostic tests available, even in middle-income country health systems, for basic tests that you need to be able to manage patients. If you then, and the bar graph that you can see on the right-hand side of this slide is work that FIND did to inform our own strategy. We had a look at how big is the diagnostics gap. By that I mean, how big is the problem of people undiagnosed with the disease versus those who are diagnosed with the disease and then cannot access it. So the therapeutics gap. How big is the diagnostics gap relative to some of these challenges? And what you can see, and here you've got graphs across a series of diseases, TB, HIV, hepatitis C, diabetes, and hypertension, is that the diagnostics gap, largely due to the great work of access to medicines advocates, is then larger in many cases than the access to therapeutics gap. So most people don't know their diagnosis. And that means that they have no way of managing their disease, being linked to care and receiving treatment. So in some ways, it's the thing that you don't know because it's hard to advocate because you don't know that you have a disease yet within the system. So it tends to be this benignly neglected stepchild within health systems, but is a really big contributor to worsening health. So that's the status of diagnostics, not good. Especially at the primary care level. Most diagnosis that's happening is clinical judgment. It's not being used. There's no tests like we're used to having that are being used to inform. So let's talk a little bit about COVID, because COVID really changed the game. And I'm really going to focus quite heavily on the first year, so heavily on 2020. That's part of the COVID response, building out that toolkit of tests. I think that has a lot of really interesting lessons when it comes to other innovations. So if you're thinking about, I don't know, a new technology that helps maternal mortality, or a new care algorithm for patients with diabetes, I think a lot of these same lessons are applicable How do you kind of develop these new ideas within global health? How do you then get them out within health systems? What are some of the barriers you're going to see? We probably saw all of them when it came to COVID testing. So COVID changed the dynamic for diagnostic testing. As I said, it had always been the sort of abandoned stepchild of global health. But suddenly, and you may remember this yourselves from early 2020, COVID testing became top of the agenda. And if you had a COVID or access to a COVID test, you were really, you were in some luxury here. Many of you may remember the queues of people to get PCR testing for COVID, the inability to get it when you had symptoms early in 2020. And this was a universal global experience. So you had global leaders, perhaps for the first time in history, who engaged on what their diagnostic testing infrastructure looked like in countries and where those gaps were. For the first time in history, presidents and prime ministers were briefed daily on the number of tests that were done for an individual disease, and we'll probably never see that again. But I can tell you that in other disease worlds like tuberculosis, where maybe a prime minister looks at the number 3 years old from 5 years ago, this is really quite a radical change on the baseline. So what was the global response, especially early 2020? And one of the key things that happened, which was launched by the European Commission, WHO, and a few other groups, was the ACT-Accelerator, which had 4 different parts to it. It had each of which was a different pillar, each of which was co-convened by several different existing global health organizations. So this was perhaps one of the marquee global partnerships for the COVID response, not certainly the only one. It was created in a real hurry, like over the course of hours to days, not over the course of years to decades, which is the normal course when you create a kind of consensus for a new global health organization. And that was why it pulled a lot on existing organizations within the global health architecture. It had quite a decentralized and consensus-driven decision-making process because there wasn't time to sort of establish all of those working norms. And if you can imagine putting yourselves back, as you all remember, from March 2020, it was unclear how bad it was. So we needed this decentralized infrastructure. So each of the pillars was co-convened by different organizations. Some of you might be familiar with COVAX, which was co-convened by Gavi and CEPI, which is the vaccines pillar. The therapeutics pillar, co-convened by the Wellcome Trust and by Unitaid. The diagnostics pillar, which we'll talk a bit about today, co-convened by FIND and the Global Fund. And then the cross-cutting health systems connector, co-convened by WHO, by the World Bank, and by the Global Fund. So this was the sort of basic structure, as I said, that created over hours to days early in the pandemic to be able to help support the global response when it was clear that there was a need for this concerted global effort to be able to respond. So the diagnostics pillar, co-convened by Global Fund and FIND, and this was the structure that we used behind it. It pulled together about 50 different organizations in the end to work in an end-to-end manner. You may remember at this point, there was only PCR testing in laboratories. So by that point, we'll talk a little bit about the timeline. We had some tools for diagnostics, but we were missing a lot of the tools that were going to be needed for a concerted COVID response. So there was a need for this partnership to work from the R&D end to be able to develop the tool right through to the deployment of those tests, and later to be able to work in spaces like genomic surveillance to be able to identify new variants as they arise. So I think those are the main characteristics I was keen to highlight here. I think because some of the significant access gaps were especially in low and middle income countries, and because the organizations who were leading this work had a focus on low and middle income countries, that was very much where the pillar was focused. And its goal was really to sort of articulate to be an information sharing platform, to articulate those sort of shared needs, to have a clear vision for what tools were needed in the toolkit, and to sort of, to some degree, coordinate the actions of global players to be able to fill some of those gaps. So that was sort of, I think, broadly its mandate. So that's all I'm going to talk about on the partnership itself. I'm going to talk a little bit about what happened for the development of COVID diagnostic tests. So switch a little bit from thinking about that political global health architecture to perhaps more of a technology focus. And what you can see here on this slide is the timeline of the development of different parts of the diagnostics response to COVID. So the first case, as many of you know, was reported or notified to WHO at the end of December 2019. By mid-January 2020, the first genetic code was available for SARS-CoV-2 that was shared globally. And there was an incredible push at that point to be able to get the first diagnostic tests out. WHO began shipping COVID PCR testing to every country's central reference laboratory by the end of February. So this was a 6-week timeline so that every country was able to do COVID testing. The difference between every country being able to do that in one central reference laboratory and all of the patients who needed COVID testing being able to access it was a significant gap. And that was, I think, the point where the ACT-Accelerator and other partnerships really engaged. So you had this, really quite incredible triumph of science to be able to get those tests out so quickly. They were shipped via diplomatic courier to countries, and so every central reference laboratory was able to confirm if COVID was present. But the scale of the emergency was so big that there was really then a significant access gap for going from the central reference hospital, say, at Port Down, to being able to access it in Liverpool and Edinburgh and all of the places that were going to then need testing. To give you an example of what diagnostic testing timelines look like, and it's obviously not a perfect example developed at a different time, you see on the bottom of this slide is what it was like to develop malaria rapid diagnostic tests. So if any of you have ever had malaria or suspect malaria, you might be familiar with these tests. They're a finger prick blood test used to confirm whether you have malaria. It very much looks like a sort of pregnancy test in simplicity. So in the early 1990s, you saw the emergence of the first of these sorts of tests, but they were terrible into market. And many of you might remember the same story with the first COVID rapid tests from early 2020. And it took the best part of 10 years from that point to an agreement on what a good malaria test looked like, and to be able to actually provide better information on which tests countries should buy, and actually have these tests scaled within health systems. Took decades and decades. So that's really important framing when we start talking about timelines that last months versus timelines that take decades, as to the difference into the acceleration of the scale of the technology that's required for COVID. So, as I said, I've really just focused on that first top left box for January 2020 and the non-existent box that we should have for February 2020 for the sort of transmission or spread of those first COVID diagnostic tests. But what became clear at that point was that especially centralized PCR testing was going to be inadequate for what was going to be needed for an effective global health response in most countries. And one of the first priorities that was identified was to get high-performing rapid diagnostic tests that were available and to get those tests out. And so what you then saw through 2020 was a real scientific race to find the right tests that performed at the minimum standards that were required. And even what those standards were was a topic of open debate, and then scale. So by September 2020, WHO had introduced some interim guidance for the use of rapid tests. That same September, the first tests received WHO emergency list authorization, which was needed for many countries to have assurance to be able to buy these tests. And the ACT-Accelerator Partnership provided $120 million borrowing value guarantee to the first 2 manufacturers who reached market to be able to ensure that low middle income countries could procure testing. Because there was a concern, as there had been for the first sets of diagnostic testing, that all those tests would get taken by high-income countries and that there would be no supply available for low-income countries who even wanted to be able to buy these tests. So there was essentially a pre-booked volume that was put aside for low-income countries to be able to buy those tests. And then the market continued to evolve quite rapidly, including work to continue to bring down their price. The first tests hit the market at $5 per test, ex works. By 3 or 4 months later, that price had been halved. now, or within a year of that, they were then halved again to closer to $1 US ex-works per test. So really rapid evolution in the identification of needs, development of the technology, regulatory space around it, then the launch and scale of those tests, especially compared to some similar technologies that have been in the market. But I don't want to paint it as a good story. I'm going to talk a little bit around some of the significant equity gaps that emerged around diagnostic testing for COVID and their long-term implications. So along with, as you can imagine, that growth on the science side of the technology, there was growth, and this is manufacturing volumes for COVID rapid diagnostic tests. That's an antigen rapid diagnostic test, if you're wondering what an AGRDT is. So these are those ones that you've got in your cupboard for testing for the presence of COVID. And this is a global manufacturing capacity for diagnostic tests. The gray box being, as you see, this huge emergence of this graph over time, being the COVID antigen rapid diagnostic tests. And then there's a small blue box you can see at the bottom, which is the antibody tests, which were not so relevant with the clinical management of diseases, but continue to be manufactured. And to give you a comparison as to what an expansion of manufacturing, you can see those red lines at the bottom. This is all the other rapid diagnostic tests, pregnancy tests, malaria tests, HIV tests, all of these other tests. So global manufacturers rushed to be able to scale up manufacturing for rapid diagnostic tests for COVID. And there was an explosion in the manufacturing production capacity through 2021. So late 2020, when that volume guarantee was announced, volumes were still pretty low on the left-hand side of this graph. As you can see, it was a really rapidly evolving market. And currently there's a lot of, as you can imagine, excess production capacity that's out there. This production capacity was highly concentrated in a few geographies. So the first two tests to receive WHO emergency use listing are manufactured down the road from each other in Seoul, which is really quite a significant challenge when it comes to having diversity in supply and knowing that you have resiliency in your supply chain if both of them are produced on the same street. The supply by the same ultra-soup transformer could be flooded by the same storm and taken out of commission. So, and I'm not really focused so much on the broader topics of manufacturing in this presentation, but just as they're expanding that base of global manufacturing is quite a lot of the work that FIND and others have done to be able to provide a bit more surety in the ongoing supply of diagnostics. Because where I really wanted to focus was around testing equity and what was really happening within countries. And what you can see here is the tests per population per day for income. The red line that you can see on that graph is the explosion of testing that happened in high-income countries. And the three lines that you can see at the bottom, barely making it off the x-axis, are the testing rates, particularly in low, middle, and low-income countries, although also in upper middle-income countries. So even though you had this explosion of science of tests designed for use in low, middle-income country settings, even though you had the manufacturing capacity there, the global policy pieces there, you actually had an explosion in inequity and access to diagnostic testing that is happening between different country groups, despite the fact that as you got sort of later in 2020 and into 2021, you were seeing waves of COVID, particularly hit countries like South Africa, India, and others. So there was a significant mismatch. And you can see that comparison in the numbers to the right, which shows this 5 to 10-fold difference that we saw, in fact, up to 90-fold difference that we saw in testing rates between high-income countries and low-middle countries, which is really quite a significant gap. And we'll talk a little bit about what the implications of that were for being able to effectively manage the global COVID response, to be able to spot new variants, to be able to launch new therapeutics, all of those things, which obviously links to access to testing as a baseline. So one of the things that the ACT-Accelerator Partnership did by the time you get to sort of the right-hand side of the slide, when the extent of that equity gap was becoming apparent, was to start asking the question, why, right? Why, when those tests were available, they could be procured, Why were they not being procured? And those were questions that we asked both to country and government stakeholders, but also to communities. So I'm going to touch a little bit on what some of those data points were, because they speak to the complexities of having a valuable intervention or innovation that's available in market, but actually getting them deployed within the reality of most health systems is incredibly complicated. And we'll talk a bit about what some of those complications were. So when we asked countries why they were struggling to be able to take up these diagnostic tests, these were some of the things that we heard from ministries of health, from international organizations and countries and others. And they largely came down to a few questions, one of which was around some of the points that we talked about with Roger's diffusion of innovation theory earlier around the trialability of some of these things, the relative advantage or perceived relative advantage of some of these things. So one of the big questions was, how do they deploy these within health systems? Because normally you have evidence from pilots and implementation studies, but the pressures from COVID were so big, high-income countries were able to use their research institutions to generate that evidence, to be able to deploy them quite aggressively. Many of you might remember quite aggressive deployment of rapid tests here in the UK that was driven by evidence that was generated internally. But for many low-middle-income countries, they would have to wait for WHO guidance, recommendation, information to come out. It's a much slower process for them. There wasn't necessarily that same evidence generation coming from national institutions to be able to inform that policy. So there's a real gap between the technology and the evidence and how to use them. So the technology had come first, the evidence on how to use them was still coming in many countries by late 2020, early 2021. So policy and testing strategies, how do they use these? Hesitancy, because many of you might remember there'd been some bad tests that had hit the market in early 2020. And people remember these and were anxious about them deploying better tests that came out, even after they'd gone through the WHO pre-qualification process. There was challenges around how to deploy them within health systems. So how do you then manage to get them out? How do you get the data back to the system? There was challenges around funding, and this was one of the big challenges for the ACT-A partnership, was especially around the timing of the funding. So the tests became available at the end of Q3, early Q4 2020. There was then funding that came through for the procurement of these tests by the Global Fund C19 RM, but that happened 3 to 6 months later. So countries heard about this new technology, they heard about this new policy from WHO, they didn't have any access to resourcing to be able to procure these tests until a little bit of time later. And so being able to line up that funding, policy and evidence piece was really difficult in the quite chaotic world of COVID. The other thing we did was we asked communities on access to testing. So one of the big debates that was happening at the global level at that time was how much testing is enough testing to be able to form a good global health response. And that was quite a topic of debate from technical experts. So what we did was we pivoted that question to ask communities, assuming that everybody who should be able to get a test and thinks they need a test should be able to access the test, were you then able to access the test? And we did the survey across 10 countries, and actually over 50% of people who said they needed the test were unable to access the test, which is an unsurprising statistic, really, considering the access gap that we've just described on some previous slides. So we knew that people who needed the test were unable to access them. And we knew that that was particularly true in low middle income countries. And we knew that the equity gap when you looked at testing per population was significant. So we could see that gap. Why? So communities pointed to lack of testing facilities in their area, by which we knew that they were using PCR testing, central laboratories, you had to go to a single point, weren't using rapid tests that could be deployed at a local level. High pricing of tests, which again speaks to how effective the public sector was at delivering or not testing. People were having to go private. Lack of knowledge about where to go and get testing, and having to travel to be able to access testing. And this is all at a time when simple tests were available, but they were just not getting out to communities, despite this quite clear need that had been articulated from some of these strategies. So at that point, a whole bunch of organizations, FIND being one, but many, many different partners, FIND alone through our partners was working in about 50 countries, Global Fund, many, many more than that, other stakeholders involved in ACT-A, many more than that, to be able to generate evidence on how to use some of these new tests that were coming out of the system. So really to catch up that technology to evidence gap a little more. I just wanted to give you one example of that work, and that was work that the team was doing in South Africa, integrating COVID testing with TB screening, which present with some, although not identical symptoms, but can have some of the same set of symptoms, presenting with coughing, presenting with fever. And so this was really testing to take rapid tests out into schools and sporting events and workplaces and other places where people congregate to be able to bring much more active testing to communities. We did testing at taxi ranks in South Africa and Kenya and elsewhere. And that was really to generate the evidence that governments might need to feel comfortable to be able to produce guidance or policy change to be able to expand access to testing, to kind of get from that really control model to a much more liberal deployment of COVID diagnostic testing. As I said, this is just one example. There was a lot of different work that was going on to essentially catch up that technology to evidence gap. But still, testing gaps are really significant. And as you can imagine, that's not like we closed that gap that I showed earlier. If that timeline had continued on after the end of Q1 2021, you would have seen that same trend. Growing, in fact, growing inequity between high income and low income testing rates. And there's really quite some consequences of that. One of which is that if you want to detect new variants for COVID, as we're starting to emerge quite heavily in that time, you have to do enough baseline testing to be able to then do genomic surveillance to be able to identify new variants. So if people aren't getting tested, you're not going to know that a new variant is. And so we, along with others, did a whole bunch of agent-based modeling and other techniques to be able to identify how long we thought it was really going to be able to identify a new variant based on current rates of testing. And the answer was much longer than most countries would accept as reasonable. Weeks and weeks instead of days that you might want to be able to identify a new variant of concern. The other area that's really relevant is around access to therapeutics, as molnupiravir and other effective oral antivirals for COVID started reaching market. One of the features of these drugs, many of you might remember, is that you have to take the drug within 5 days of symptom onset of COVID for the drug to be effective, which means you have to have access to diagnostic testing in order to be able to take them the timely therapeutic and to be able to reduce your risk of hospitalization and death from COVID. And what you can see here is the modeling work that the team did in Brazil, Georgia, and Zambia, looking at different rates of testing and how effective they are at stopping the transmission of COVID and also at essentially having public health impact from having those oral therapeutic medicines available. And the short answer is if you're not doing testing, the drugs don't make a difference from a public health perspective, which I guess is kind of obvious and intuitive at the moment, that interlinkage that exists between drugs and diagnostics if you're deploying them within a public health system. But sometimes you have to quantify these things and put them on graph for people to believe them and for them to be policy priorities. So I think that was really what some of this work was doing. And if you might remember back to this slide, so this slide, you can see that low-income countries at the point in time where this snapshot was taken were testing at 6 to 85 tests per 100,000 people per day. And that on this graph is essentially the baseline, right? So essentially at those testing rates, the widespread deployment of the therapeutics wasn't going to make a difference. And this is, I think, really important for drawing the linkages between these two, for making sure that diagnostics, along with medicines, are interlinked parts of any health systems policy or intervention. So that was the early COVID story. I think I'll stop there, but just to say, I think over that first 2 years, it was really a triumph from a scientific perspective. New technologies got developed. We went from PCR testing only to having a full toolkit of tests. Rapid tests were available, genomic sequencing was available, but a really significant gap on the equity side that was only growing over time. So what's next for diagnostics? There is some exciting news. So COVID has really spurred investment in diagnostic testing and innovation and accelerated the development pipeline by years. So this is what testing looked like sort of pre-COVID. At primary care level, you had these simple rapid tests. There was 1 or 2 of these Middle boxes, you can see these point of care machines, which are sort of PCR machines that have been simplified and miniaturized and can be put into clinics. And then there's a few of these big laboratory machines on the right-hand side. That's what a lab machine looks like. But what are we seeing over time? We're seeing spurring of innovation. This is what has happened during the pandemic. You've now got tests that are deployed at the community level. You guys have them. I still have some old dusty boxes at home of these tests. More and more tests are simplified and available at the primary care level. And if you look at the pipeline for these diagnostic tests, you see a real explosion in tests that are in late stage of development for these tests. And these include a lot of these simple devices that can do quite complicated testing, be able to identify new pandemic threats that can be deployed within primary care centers, don't need electricity, are pretty simple to use devices. So it's a really exciting technology pipeline. But I wouldn't want to go away from thinking about those significant access gaps to primary care diagnostics now, the COVID equity gap. So this technology, without some response from the global community, is largely not going to realize much public health potential because health systems have not been good at taking up diagnostic tests. In addition to those technologies, there's a whole bunch of really promising ideas that have been advanced by the investments in the science that have come through COVID. And those include point of care, simple tests that can distinguish between multiple diseases at once. So not just COVID or not COVID, but tell you whether your cough is COVID or influenza or RSV or pneumonia or any one of a million other things at one time, which is really a much more patient-centric lens and gives you much better data for surveillance systems. That includes much more wearable and tests, and finally we call this the democratization of diagnostics. So much more testing moving outside laboratories and clinics into people's homes and for people to be able to have on their mobile devices, for example. We're seeing AI coming out at the first time, both as a complementary tool to some of these tests, but also as a test in itself. So in 2021, WHO made the first recommendation on the use of AI for the screening for tuberculosis. So computer-aided detection for tuberculosis on chest X-ray. So that's the first AI recommendation that's been made for diagnostics from WHO. And as you get more and more of these simple devices, you have to start thinking about medical waste and questions of sustainability, which you get more and more of these tests that are coming, and they create much more medical waste and involve a lot more materials in manufacturing. You also think about the different channels that diagnostic testing goes out on. So traditionally, it was really managed and controlled by laboratories, by healthcare clinics. We're seeing more and more testing move outside the formal health system, which is a really big challenge for policymaking perspective in countries. In particular, pharmacy channels are really important as a route for accessing diagnostic testing. And we do a lot of work thinking about the pipeline of tests for diseases like tuberculosis, about cancer. I think, how do we use pharmacies and other channels, which are much more available? Many, many more pharmacies than there are healthcare clinics and others, to be able to access better diagnostic testing. And this is just an example of how that channel, the role that channel plays in a number of different countries where we've been looking at how people want to access self-testing. Really comes out as, aside from government clinics, the number one route people would look to access testing. There's also work at a very global macro level on the wider enabling system for diagnostic testing. So things like ACT-A and other interventions are really showing the gaps for diagnostic testing. A lot of global health stakeholders who've never thought about testing before have thought about it more in the last 2 years, and they've thought about it in their life. The excellent work from the Lancet Commission on Diagnostics, which recommended the creation of an international alliance on diagnostics, as well as really shone a light on some of those policy gaps for simple primary care diagnostics. And all of that sort of resulted in much more attention on diagnostic testing from a global health community level than there's ever been before. And at the upcoming World Health Assembly in May this year, there'll be a discussion around the resolution on diagnostics and how to strengthen diagnostic capacity within health systems, both for universal health coverage and also for surveillance, sponsored by a number of countries, in particular Eswatini on behalf of the African Union, Indonesia, and a number of other countries have co-sponsored that resolution that's going through the WHO, which talks about having diagnostic strategies for countries, about using evidence-based tools on the deployment of your laboratory systems, about making sure that access is available. So it's really helpful for drawing much more of that kind of political diplomacy within global health attention to diagnostic testing. So that's a really brief tour through diagnostic testing and what the impact of COVID has been in this space. I think there's a lot of interesting trends, both diagnostic testing is now relevant, I think, in a lot of spheres. If you're interested in global health security, if you're interested in surveillance, obviously this is where a lot of the data comes from that underpins those systems. If you're interested in quality of care within primary care, then access to diagnostic testing is really quite important. It's a great enabler of other things. It doesn't sit away or outside areas like medicines or workforce. It's really a complementary tool to those. But hopefully that's been really interesting, looking at that evolution of technology space within global health, how some global health stakeholders responded to the pandemic. And maybe I'll pause there because I've probably gone over the little video that I was going to. Oh, no, Justin, you're in charge.
No, that's great.
I'll pause for any questions and open up.
Okay, well, thank you very much. Fantastic. So, yeah, we have plenty of time for questions. And so we have about 30 people still online. Debbie, are you seeing questions in the chat?
I am actually, yeah. Do you want to take the first in the room?
Should we give preference to who actually made it in person? If anyone in the room would like to ask a question, please just introduce yourself, let us know where you're from, if you're at LSE or outside, that would be great. So would anyone in the room like to start, or I will wait a second and see, otherwise, yes.
So I'm gonna
Possibly press, there should be a button here by a microphone that may make you more audible online.
I think you have to hold it.
Press hold.
I have to hold it. Okay, yes. So I'm a student of international development here at LSE, and I thought it was really interesting the point on pharmacies. And then my question would be, how do we encourage pharmacies to do what we cannot do through primary healthcare centers or hospitals and still get the information that we were getting in those places? So for example, thinking about COVID, the moment we started doing the test at home, we stopped reporting to the authorities that we were testing positive of COVID. So how do we balance those access, but at the same time gathering the right information?
It's a really good question, especially because globally, but especially in LMICs, it's typically a very fragmented market for pharmacies. Often it's small, like mom and pop stores that are a single owner operator who's a pharmacist in those stores. So you're talking like hundreds of thousands of different organizations if you take a country like India that exists as pharmacies. One of the things that's happened in the space pre-COVID has been consolidation in the use of technology platforms to be able to enable that access. So you've seen the emergence of new startups like Clinica and Pharma that join together a lot of these very small, scattered, fragmented pharmacies, whether that's by like a shared supply chain platform or shared ownership or shared information platforms. I think Clinica, which is now SwipeRx, has like 70,000 pharmacies, for example, through Indonesia, Philippines, and a bunch of other countries. And so that allows a platform to be able to engage with this otherwise very, very fragmented and decentralized sector. That's certainly what we do or how we've approached it at the global level. One of the first things we do is ask pharmacists why providing diagnostics is hard. The kind of points that they point to are price sensitivity, so how much people are willing to pay. These are usually exquisitely price sensitive markets, and that's often a barrier, especially when new tests come out, can be a bit more expensive where a few cents count. Or information, so how comfortable they feel in doing diagnostic tests. So some of these platforms present an opportunity both to educate pharmacists on these tests, provide supply chain for them to be able to access and procure the tests themselves, as well as provide and exchange that information back on what test results they're getting. So I think some of those new organizations that are emerging in the global health space, a lot of them are through startups. So they're not like NGOs, they're private sector startups that are doing really cool things.
Great. Can I just quickly check online if they were able to hear the question when we held down the mic, or were they not able to hear the question? I don't know if anyone online can just confirm that worked. Otherwise, we'll have to repeat the question. So, yeah, okay, great. So the microphones in the room are working. Let's take an online question.
Yeah, there's a question that's come through from Bridget Lang asking, do you think the scale and intensity?
I'm sorry.
The red light.
I was thinking about this.
Apologies. This question comes from Bridget Lang. Do you think the scale and intensity of the innovation could be replicated for IDs that don't typically affect the global north?
That's a really interesting question. So largely the manufacturers of these tests, they come from very specific geographies in high concentrations. So traditionally diagnostics has really been highly concentrated in parts of Asia, especially in China and South Korea, in Europe and in the US. And there's been relatively fewer startups that have come from low middle income countries. We're starting to see manufacturers, though, looking to the diagnostics market who previously not been interested in that space in low middle countries. So, for example, we as FIND work with developers and manufacturers in Senegal, in South Africa, in Kenya, in India, and in Brazil to be able to expand that manufacturing base for diagnostic testing. So I think that's going to be a really quite critical part of that solution. Diagnostics is not a really high margin industry in the way pharmaceuticals, right? You don't see these crazy margins that we see. So it's not bad, but medical devices is not quite the same. So that really affects the ability to manufacture these diagnostic tests. Places like Diatropics in Senegal really set up very explicitly because of the problem that you just asked, which is that for a disease like schistosomiasis, for example, where there's a significant disease burden in Africa, there's no burden in high-income countries. So even though people like FIND and others might have the tests, finding someone who can manufacture and have commercial viability of those tests is really important. And that's really going to have to be around increasing the regional manufacturing for these tests in the countries that they affect. Not just relying on, at the moment, as we do, high volume, low cost manufacturers, largely in places like Korea and China.
Okay. Anyone else in the room would like to ask a question? Yes, so press the button. If the red light's on, you can be heard.
Am I audible?
No.
I think the other button. There are two buttons. There are two buttons on the button. Yeah, that's good. That's good.
Hello.
Great.
Hello. It was a great session, and my name is Anupam Das, and I'm from a healthcare IT company. My question is, as you have mentioned that this diagnostic test industry is a very cost-sensitive industry, how do we take innovations into consideration for scaling up and capacity utilization for diagnostics to take it to the mass at the global level? Is FIND working on that line?
Yeah, so we showed that graph showing the explosion in manufacturing capacity that's going on, and India will be a really classic example of this, right? So there was a significant indigenization of diagnostics initiative from the Indian government and a series of other organizations within India that was able to manufacture in the end largely PCR reagents and 1 million tests a day. So really able to kind of scale some of that volume. But one of the biggest challenges is that there's limited know-how on how to manufacture diagnostic tests, especially to be able to quality assure diagnostic tests at scale. So to be able to produce lot after lot of diagnostic tests that reach a minimum quality and performance bar, that skill in manufacturing is really quite concentrated. So a lot of the work that we do at FIND is around technical assistance for technology transfer. So companies or organizations or academic institutes might have the test. In fact, actually the development of the test is often the most straightforward part. A lot of that hard work is around transferring that manufacturing know-how, regulatory systems and other pieces to countries to be able to scale. And so if you think about things like the work of WTO and others around technology transfer, that's diagnostics. Diagnostics is a technology transfer problem, not an IP and patents problem necessarily. Does that make sense?
Should we take one or are there a lot? How many do we have? Do you think?
There's two that have come in.
Okay, so should we take both of those and then we'll come back to the room? I just see hands here.
Yeah.
So we'll do the online ones then.
So I'll give you both questions then. So the next one comes from Tony Thomas. With the proliferation of new tests, is the regulatory system in target countries and WHO able to keep pace? And the next question is, I'm curious about the focus on infectious disease diagnostics What about medical innovation for surgical diseases?
Both super good questions. Let me take the last question and then the first question. So FIND focuses on infectious diseases. It was sort of written into our early mission statement 20 years ago at a time when infectious diseases were the big threats to global health. And FIND's particularly known for its work in malaria and tuberculosis and a few other key global health diseases. We have started, though, over these last couple of years to expand some of that base to really respond to the requests from countries that we were getting around where some of the big technology gaps that they had for diagnostics, which has meant that we've launched programs in non-communicable diseases, especially for diabetes. So basic blood glucose testing, as we saw earlier, is missing in many countries, let alone the state-of-the-art testing that's available in high-income countries like continuous glucose monitoring that many diabetics will use, say, here in the UK. And also for diseases that cross over between infectious and non-infectious diseases like cervical cancer, for example. As we've started to roll out globally new vaccines for cervical cancer, we have cohorts that are moving through that will be at risk for their lifetimes of cervical cancer. Access to the vaccines for HPV, which is the vaccine that's very effective for preventing cervical cancer, is very asymmetrical globally. So we're really going to see shifts in the epidemiology of some of these diseases where the highest burden, if it doesn't already sit there, will certainly sit there in low-income countries going forward. And so some of these diagnostic tests have started to be some of the areas of focus that we work on, not just that sort of set in infectious diseases that we have as many organizations do as a kind of legacy of where the global burden was when we were established. And then on the question on regulatory systems, this is a great one. Actually, it affects high-income countries and low-income countries alike. Most of the maturity in regulatory systems is in vaccines and in pharmaceuticals, not in medical devices and diagnostics. And that means that we've seen a whole range of countries. So some countries will have legislation that exists. They might have even copy pasted it from another country into legislation, but not the supporting organization. So it might say that you go to the, I don't know, diagnostics agency of the government, but there is no diagnostics agency. And so, or there might be several competing, which at least in one regulated country, they won't name, there's two competing organizations which will both claim that they're the regulator of diagnostic testing. Some countries, all you need to do is file paperwork to be able to have your test registered to buy, which means that if you're a large procuring agency like a government, you don't actually have confidence in those regulatory processes, which often means that you then require validation of those tests within your own laboratory, which is where you run head-to-head your gold standard lab tests versus these tests to buy, which hugely delays the uptake of technologies and creates inefficiencies within those systems. So as a regulatory system, it's not half as mature as the other systems that have been engaged with. Perhaps a small silver lining to that is that countries are more aware of that than they've ever been before, because they've all watched the challenges around that with their own diagnostic testing. We saw that here in the UK, right, where there was large procurement of diagnostic testing that then had to be trashed when the performance was low on those validation studies that had to happen. So I think there is certainly momentum to reconsider what a good regulatory system looks like. You've also had the emergence of, and this actually predates COVID, building regulatory systems was a multi-decade process, but things like the African Medicines Agency, which has been now approved under the African Union, is being built over time as a potential forum to be able to strengthen country regulatory agencies. Because that process of relying on FDA or the European Medicines Agency, or even, relying wholly on WHO as a system, and they're not a regulator. That just doesn't work when you need to be able to get, new innovation out. And I think there's more and more appreciation of that. That said, it's a very slow moving space. If anyone works in a regulatory space, good on you. That's a slow moving.
Okay, great. I think we do have time for one or two more. We've gone the hour, but actually we have the room for more than that. So there's one more hand I saw in the room. Would anyone else get your hand up if anyone else would like to ask? Yeah, Mike also. Okay, so we'll start here. We'll take two from the room. Please.
I think you'll hold it down.
Press and hold is working.
Yeah, and hold it down.
Okay, I keep on holding it.
Yeah.
Sorry, that's a distraction. So I'm trying to see the policy making process here. So these four pillars that you have shown, who made those pillars and what is their respective responsibilities and how they are monitored.
Sure.
And second, I want to see this. After that, I have a question on the bottlenecks you are talking about at the country level. So I understand that FIND is basically diagnostic pillar. That's what you do. But you have to work with other pillars as well. So how did you coordinate these? Who are these people who set up those pillars? And how did they work with the respective countries, especially in Africa? I work for African Union and I used to teach in the University of Birmingham. So that's why I'm asking.
Should we take Michael's question as well?
This one? Yeah, I mean, you started off by, talking about rapid diagnostic tests in malaria, and I'm just interested if you could maybe draw some lessons from the COVID, particularly for malaria and TB, but more generally, as was pointed out, for more, diseases of the South, or because I'm not really sure what lessons come out of the COVID that would accelerate, say, the space within malaria, for example. And because there are diagnostic tests, as you say, available, and so, but they're not necessarily being used appropriately. So I'm just interested in your reflections.
Yeah, absolutely. So the 4 pillars of that, so back to the first question, then we'll come back down to some of these last questions. So the 4 pillars of the ACT-Accelerator, they were put together by WHO, by the European Commission, and by a few other organizations. And the sort of macro governing structure is the member state structure of WHO, where every country then has a membership within those sort of governance structures. It's largely by consent and agreement. So amongst all of the global agencies, and there's I think 10 that are the most closely involved: the Global Fund, Gavi, CEPI, FIND, and others. They all have their own internal governance structures as organizations. And then they essentially kind of share a platform of priorities, a resource mobilization platform, a coordination platform. And the governance comes at an ACT-A level to that member state structure for WHO, and then within each organization's own existing governance processes. And that was really because ACT-A was put together in a hurry. So if you want to if we decided tomorrow to create a new global organization like the Global Fund, Michael, I remember talking to Diane, the Global Fund was about 6 years in creation, full time. We didn't have that time within COVID, which is why it became sort of using those existing structures where one could to be able to put that together. This is why there's a lot of discussion now about a new pandemic treaty, around things like a new medical countermeasures platform, so that we don't have to just invent a huge global partnership overnight to fight one of the largest threats that we've ever seen, the way that we had to back in 2020. So I think the idea is that we won't have to repeat those experiences or perhaps apply those same band-aids. Does that make sense? Go ahead.
Yes, so now coming to the bottlenecks, these bottlenecks that you have talked about, in one of your slides, I think that is the most important slide for the policy. Who identified those bottlenecks, and did you give kind of the countries? To the countries, I have worked in, because it's African Union, I have worked in many African countries as well as in Asian countries. There is a capacity problem, for example. Did you give any kind of strategies or plans? How did you? Do you have give them any strategy, for example, how they manage the health workforce, for example? Delivery means health workforce. Who else will be delivering? So is there any plan that was given through those 4 pillars? Or what are their HRS plan, for example, or health workforce plan? Because they are the ones who are going to deliver the thing. And obviously, if you are taking health workforce time away from into the COVID, that means most of the time you are taking from the regular treatments and regular vaccinations and things of that sort. So how it was planned, especially in developing countries? Because I was emergency evacuated from Ethiopia in March of 2020. I know quite a lot about Britain. I went back there immediately after 6-8 months. But the point is that a lot of these diagnostic tests, as well as the vaccinations, were in a big mess. So
absolutely. It's a really good question. So each of the different pillars from ACT-A, diagnostics, therapeutics, and vaccines, had to grapple with this access and policy problem in countries at different times. So the diagnostics were the first of the available technologies, right? Then vaccines came late 2020, and then therapeutics didn't come until, in fact, they're really being available in countries now for molnupiravir, at least. So each of the different parts had to grapple with how do you deploy a new innovation at different points in the system, and we're at different periods of planning if you took only one slice at a time. So for diagnostics, for the ACT-Accelerator, because it works through existing organizations, then what you saw was essentially how do we use some of those existing organizations that work in country to be able to bring together with a sort of shared view on what the best technology looked like, to be able to get the right WHO guidance, which often takes quite some time to filter down to countries, out to countries much more quickly. So examples include the C19RM mechanism, which was the global funds mechanism to be able to get large-scale support that was used to procure a lot of the diagnostic tests to be able to cover the sort of staff and health worker salaries. It was also the mechanism where information was shared for, say, either non-international or country non-governmental organizations, EPHI as an example in Ethiopia, or CHI or cells that find or others who work with governments to be able to help design policies. So that work. I would say it was one of the biggest challenges because you only need to develop the diagnostics at the global level, and this was a global level partnership. When you then need to deploy that within hundreds of different countries and hundreds of thousands of different subunits of countries in cases, that's when it becomes really difficult. And being able to design a global partnership that does that effectively over a short period of time is really, really hard. So I can tell you what we did. I think if you measured that against the extent of the need, there was really quite considerable gaps. And I think that's one of the things that folks have been thinking about when it comes to some of the new medical countermeasures platforms is how do you avoid the extent of that gap, right? Not just that you can kind of do what you can, as was done during COVID, but like what's actually needed to effectively meet needs. And I think that's where some of those big gaps are that we're running. I think when it comes to RDTs for malaria or tuberculosis tests and what some of the lessons are, I've thought a lot about it because I think there maybe is some small silver lining on some of these things. And with a few colleagues and other collaborators have been on it a few times. So I think there's a few areas that have high potential to be able to be used. TB and COVID have some of the strongest crossovers in terms of shared symptomatology, but even for diseases like malaria, maybe even for HIV, there's some shared lessons. And those include the political prioritization of diagnostic testing. So the familiarity, on terms like sensitivity and specificity that prime ministers and presidents have right now after going through COVID. How do we use that for an advantage for other diseases? Their familiarity with this part of the testing infrastructure. That connection between surveillance, global health security, economic success, and diagnostic testing has never been as clear. You don't need to make that argument to countries or to political leaders. So how do we take advantage of some of those things? People are much more familiar with self-testing, both communities and healthcare workers. So how do we use that as a platform to get out wider diagnostic testing for diseases like malaria, HIV, and for TB? And then the cool technologies that allow you to move what should be really complicated central testing with very highly trained staff right down to the community. So I think those are just some of the ways we can take advantage. We then need to actually implement it. It won't happen particularly. And so some of the things like the WHO resolution to be able to put diagnostics at the top of the mind for ministers of health and director generals and secretaries of health to attend there. I think that's really important as one sort of vehicle. I think being able to get some of these technologies into people's hands so they can really touch and feel them and imagine what they might look like deployed within their primary care systems. And to be able to articulate the case for why better access on a regular Wednesday in a regular healthcare clinic to diagnostic testing helps you spot an extraordinary Wednesday when a new outbreak happens and make that case around global health security. I think those might be some of the places.
Okay, so there's one last question. Oh, I think you're okay to take two more questions. One online and then one in the room.
Right. So this one is about how do you see the adoption and reimbursement of combined tools to increase diagnostic power, such as biomarker, AI plus imaging? We talked a bit about that earlier, actually. Yeah.
Should we take the question in the room as well? Okay.
Yes.
And please let us know who you are.
My name is Siabo Mandwandwe, and I am from ECL, and I've worked in international development previous lives. I'm interested, you touched on how reorganizing care can help in scaling up diagnostic, particularly ensuring these tests are available in pharmacies, etc. But how could we sort of retweak how we finance diagnostics to ensure that they can be scaled up at a national level, and also paying particular attention to equitable, sustainable and equitable access to these diagnostics?
Super good question. So when it comes to some of these vertical technologies, like these multiplexing tests that can tell you whether you have, 1 of 10 different diseases or 100 different diseases, they don't fit in well in health systems that are designed for vertical single disease programs, right? Where diagnostic testing is governed by the HIV program or the TB program. When you talk about these cross-cutting technologies, it's really hard to imagine. And so figuring out how to do that is one of the challenges, certainly the access team that FIND faces, for example, because otherwise, even though we can all imagine the value of these diagnostic tests, we can see how they'd be helpful for higher quality patient care, we can see how they'd be helpful for surveillance systems. They won't be able to be easily realized within the systems how they're currently organized. There's no chief diagnostics officer within ministries of health. His job is to govern diagnostics system. Nobody is singularly responsible for these areas. So that's what I mean by they kind of suffer from benign systems. Certainly the linkage to surveillance is really important because many countries are investing very heavily at the moment in building out their surveillance systems based on the lessons from COVID-19 with their systems. But I don't think we yet fully cracked how to get some of this full tech out, especially because it has this additional layer of complexity. Trying to put a flexible product into a health system that's highly verticalized is a really big challenge. And the question on financing and diagnostics, I think it's a great one. We know that there's almost no financing that's available. You look at that earlier graph from the Lancet Commission, what you see is better availability on malaria and HIV. And I think that's the good work of the Global Fund and others to be able to get diagnostic testing out. But pregnancy tests that have been available for 30 years and cost 10 or 20 cents and not available at all. Diabetes, blood glucometers are not available in primary care. So I can tell you how we've started thinking about some of those things. One is that WHO has launched the essential diagnostics list to get countries to prioritize what tests should be at different parts of their health system. The first of which was launched, I think, 2018. And that WHA resolution will include an emphasis on that. Some folks, actually Divya and I, so Divya would be a good person to talk to on this, have been looking at how social health insurance programs treat diagnostic testing within packages of care, to be able to see, is there some interventions that can help, make sure that diagnostics are more clearly available as social health insurance programs start becoming more and more relevant, particularly for middle-income countries, but also some low-income countries as well, who are moving in some of that space. So I think that's just some of the ways that we've sort of started thinking about it. It's definitely, because we're not a big funder, FIND is teeny tiny next to the size of these other global health organizations. It forces us to work in a situation of scarcity and perhaps a bit more creativity on some of these things than if we are like the World Bank or even the Global Fund. Although Michael would argue there's a lot of creativity. But yeah, I think it pushes you to figure out how to get other people to spend their money on diagnostic testing, because you're not going to be the ones who own or steer it, like it being the traditional model of global, right? Creative financing mechanism and fund it.
Okay. If there's no more pressing questions, I think we just can say thank you very much again. Thank you to Emma for a wonderful talk. Really interesting. Thank you for joining online. Thank you, Carl, online, who has been helping to organize on behalf of the Global Health Initiative. And Divya, thanks so much for managing making my life very, very easy. So all I have to do is kind of keep time. If you're not already signed up to the Global Health Initiative, email globalhealth@lse.ac.uk. You can get on our newsletter for future events. But thank you all for joining, and we hope a recording might be available as soon as technology works as well. Well, thank you again.
Thank you. Thank you all.
Have a good night.
I think when you look at this, probably.
I think it's a big difference.